My name's Cara Wasywich. I'm a cardiologist, and this is Arthur Coverdale, also a cardiologist. We both work at Auckland Heart Group and Auckland Hospital, and we're going to talk to you about heart failure. This hopefully will be an interactive session, so please ask us questions. We don't mind being interrupted. We ran out of time in the last session, so we'll try and go slightly faster this time to give you time for questions. And the way we're going to structure it is a case, some discussion about heart failure and management, and another case, and a couple more if there's time, although I suspect there won't be. So we'll start. So first of all, I'm just going to present the case of a man who I met toward the end of last year, a 53-year-old male with some vascular risk factors, a history of hypertension and newly diagnosed impaired fasting glucose. He was overweight. And although he was adopted, he thought there was a family history of premature vascular disease from the family history that he had. And he had not been very well for a few months prior to the diagnosis of heart failure being made. He'd been a bit wheezy and breathless on exertion, and initially was felt to have asthma. He was given some inhalers by his GP and a course of antibiotics, which didn't seem to improve the situation, and he was getting progressively worse. He presented to his GP with quite significant symptoms, and by then had clear-cut heart failure symptoms. He had orthopnea, paroxysmal nocturnal dyspnea and ankle swelling, and an BNP was performed which was markedly elevated, confirming the diagnosis of heart failure. Appropriately, he was admitted to hospital, and when he was initially seen, he was noted to be tachycardic. And I always think this is a concern. Sinus tachycardia, not atrial fibrillation, but when you're tachycardic, it means your stroke volume is low, and so you need a higher heart rate to produce the same cardiac output. He was hypotensive and had relatively normal oxygenation. He was given a small dose of furosemide in the emergency department, and in fact had a very good improvement in his breathlessness with this. And inappropriately, I think, was discharged from hospital the following day on a very small dose of diuretic with a plan for outpatient follow-up. He did have some investigations prior to going home. This is his chest x-ray, and as you can see, this is a bit stretched to fit the slide format, but he has cardiomegaly and he has interstitial congestion, increase in his interstitial markings and fluid in his fissure here, consistent with pulmonary edema. Before he went home, he had an echocardiogram, and I just am putting this up really to go through with you the things that are important in this echo. First of all, he has a very big heart, so his LV diastolic diameter is 7.5 centimetres. Normal in a sort of biggish person is probably up to about 5.6 centimetres. The squeeze of his heart is very poor. He has a low fractional shortening and a very poor ejection fraction, 18%. He's got left ventricular hypertrophy with thickening of the septum and the posterior wall, and low cardiac output with a cardiac index of 1.7 litres per minute. So this is someone who presents in heart failure with very severe left ventricular systolic dysfunction and some functional valvular regurgitation. This man needs good treatment and close follow-up. He was referred by his GP to see me in the clinic, and when he came, in fact, he was feeling pretty much back to normal again. He'd responded very nicely to the diuresis and was not so breathless on exertion. He still was tachycardic and hypotensive, and his JVP was slightly elevated. His examination was fairly unremarkable, although he did have a displaced apex beat. And he continued to have sinus tachycardia on his ECG with LV hypertrophy and some repolarization abnormalities, which often are seen in LV dilatation. So just to illustrate the importance of thinking about why heart failure. So heart failure is a syndrome. It's not a diagnosis in and of itself. And we need to think about why this has developed and treat causes which are contributing. And so in someone with multiple vascular risk factors, coronary artery disease is an important consideration. Often LV dysfunction in the setting of coronary disease is a regional, you see a regional pattern of LV impairment on the echo. If you have severe three-vessel disease, you can see global LV dysfunction like we saw in this case. Does this man have a hypertensive cardiomyopathy? Usually that would present with heart failure with preserved ejection fraction and an increase in wall thickness. But in the very end stage hypertensive cardiomyopathy, you get LV dilatation, and so that's not entirely impossible. Commonly, we will assign a diagnosis of a dilated cardiomyopathy with no other cause identified. Frequently, we see cases of familial cardiomyopathy. 10 to 20% of dilated cardiomyopathy is thought to be familial, and there are genes that have been identified that contribute to that. And then occasionally we see unusual causes such as cardiac sarcoidosis, where you get replacement of the left ventricular myocardium and the right ventricle, often with granulomatous scar. And that can present with a regional pattern of LV dysfunction and often RV dysfunction also. So this man's diagnostic workup included imaging of his coronaries. You could do a CT coronary angiogram, and we quite often do in this situation. We beta block patients for CT to slow the heart rate down to improve image quality. And so I decided to do an invasive angiogram on this man with his risk factors. I thought there was a reasonable chance of him having significant coronary disease, but in fact he had only mild irregularities. And to further clarify the situation, he had a cardiac MRI scan, which showed severe LV impairment and mild LVH, but nothing else consistent with a diagnosis of dilated cardiomyopathy. Treatment, and we'll go over this a little bit more with Arthur's discussion. So started on standard medical therapy for heart failure, beta blocker, ACE inhibitor, and an aldosterone receptor blocker, and up-titrated those to target doses, treated his impaired fasting glucose and his dyslipidemia and his congestion with furosemide. In fact, he had progression of his conduction disease and developed a left bundle branch block pattern on his ECG. He continued to have severe LV impairment despite good medical therapy, and has subsequently come forward for a CRT implantation, a 3-lead pacemaker to try and resynchronize contractility, which in patients with LV impairment and left bundle is associated with an improvement in ejection fraction and prognosis. And he's due to come back and see me shortly for his follow-up imaging. Just one final thing to mention in a young patient like this is that there are opportunities for the future here. I'm a transplant doctor, and in someone like this, I always think about, is this person going to be someone who may come to transplant in the future? And I think in someone like this, yes, potentially they are. There are many relative and absolute contraindications to transplant, and this is the time to fix those if you have the opportunity. So this man is overweight, and that is in fact a contraindication to transplant. We find it very hard to get adequately sized donors to overweight patients, and in fact outcomes are poorer after transplant if you are obese. And so he needs to lose weight and get his BMI down toward 30 or below, if at all humanly possible. Otherwise, transplant won't be an option for him. Alcohol is a contributor to LV dysfunction, and in someone like this with a very bad ventricle, they should stop drinking alcohol completely. In fact, this man didn't drink alcohol at all, as that is likely to assist in recovery of function. Ongoing alcohol consumption in this sort of situation would be a contraindication to transplant. Stopping smoking if the patient is a smoker, and stopping illicit drug use, methamphetamine we discussed in the previous workshop, can contribute to LV dysfunction. Very important to educate the patient and help them with heart failure self-management. That will help their heart failure, but if they can manage heart failure in the complicated drug regimen very well, they're going to be good at the complicated drug regimen post-transplant if they come to that. And management of diabetes is really important too, because multiple end organ complications would rule out transplant as an option. So just making sure that those things are sorted out early in the disease process, so that if things do get worse, they have opportunities for other types of advanced therapy.
So the therapies that we have for heart failure are really based on, they're very strong, with a high level of evidence, strong indication for therapy. That's called Class 1, and many of the treatments we have for heart failure now are Class 1 drugs. Class 2A, according to the American Heart Association, is a moderate degree of evidence, and you could interpret that as you could give those drugs. Now, the two types of heart failure, there's systolic heart failure, which is reduced ejection fraction, and for that we have many proven therapies. We'll discuss those. And there's diastolic heart failure or preserved ejection fraction, and these patients tend to have a near normal or normal ejection fraction, but despite the fact that they almost equal the number of patients with systolic heart failure with reduced ejection fraction, in this group there are no definite proven therapies at this stage. And so, but this is going to change very rapidly, I suspect, and so we will need to just keep out for that. And there's a sort of mid-range type of terminology nowadays where patients can occupy that sort of mid-range ejection fraction. Some patients get better, reduced ejection fraction can become normal with treatment or with avoidance of alcohol or toxic drugs. And patients with preserved ejection fraction can go downwards into reduced ejection fraction. An important thing is that ejection fraction, whatever it is not closely related to your symptomatic status. So you can have bad left ventricle with no symptoms, or you can have a very good left ventricle from a systolic point of view, but still important symptoms. This is just an example. I think I might just skip here, but we look at also the hemodynamically, we look at the left ventricular end diastolic pressure, which is mildly raised here, but it looks like a fairly normal contractility, and this is so that you could see that with preserved ejection fraction perhaps, but here with low ejection fraction, the EDP is elevated, and also it's hypotension, and the shape of the upstroke here is very much delayed. So that's now the important causes of congestive heart failure, all the usual suspects here, but uncontrolled atrial fibrillation is an important cause as well, and we see that increasingly frequently, I think, because atrial fibrillation is more common, and if you have tachycardia, it causes left ventricular impairment over time, so we have to control the rate. And as Cara mentioned, genetic causes are also significant, and there are other areas where it can cause heart failure. So the important message here, I think, is that heart failure is usually a consequence of pre-existing disease, and this takes its form at the sort of grassroots level in stage A, where you're potentially at high risk if you've got these sort of risk factors, and I think this sort of stage is where you can identify and manage these patients and select and to try and prevent them from going to stage B, where you start to get structural heart disease, and by that stage you're on the road to getting symptomatic heart failure with which is stage C, and most patients with obvious heart failure in stage C, and then it's just another step beyond that where you get into intractable heart failure, where treatment becomes more difficult, and you often have to have repeated hospitalizations and specialized therapy and intervention sometimes. So many of the risk factors for heart failure are the same for coronary artery disease and stroke. Now, the standard heart failure management is something which you will all know, is that it began really in the mid-1980s with the ACE inhibitor trials, and then of course there was the beta blocker trials which followed. So the main things here, if you see a patient with heart failure, we've got to stabilize them, rate control, often give intravenous diuretics. Sometimes if they're very severely affected, they need to be in hospital very often, and inotropes. We use general measures restricting salt and fluid, monitoring renal function and electrolytes, and stop drugs which might exacerbate heart failure. Tests, ECG, echo, crucial. Chest X-ray we of course do. BNP levels are useful, particularly trying to make a diagnosis of heart failure, but they're not. But there's controversy as to whether or not repeated measurements of BNP are useful, and I think the weight of argument at present is that they're probably not, but the jury's still out of it on that matter. So just once is sufficient if you have to do it at all. Of course, if people are in obvious heart failure, there's no much point measuring them at all. And then to consider intervention, and that could include any of those interventions, coronary artery surgery, valve surgery, or CRT or ICD. And I think for management of heart failure, a team approach is useful, very useful. And so, and also it's important to give patients adequate education about their condition, because it's not straightforward very often, and they have to have good adherence to a complex way of medications. So the new drugs for heart failure, well, spironolactone is not a new drug, but it is one of the class 1 recommendations for patients with heart failure with a reduced ejection fraction and symptoms. And eplerenone is another aldosterone antagonist. It's a bit more selective, and it was shown in 2 trials to be effective both for indications for spironolactone, but also in patients with low ejection fraction with relatively mild symptoms, improving outcome, survival, etc. So that is an important addition to our treatment portfolio. And it was finally approved by PHIMAC in the first week of July, I think it was, 8 years after it was the trial, and you can get it on special authority. So eplerenone and finerenone, which is similar but may have advantages, I don't know. We haven't got trial data to tell us, I think, at this stage very clearly. But you do avoid gynecomastia, which spironolactone doesn't. So the new drug therapy for the aldosterone antagonists in heart failure, the important considerations for using them. First of all, you should be on optimal tolerated standard therapy as well, and you really need to closely monitor renal function and potassium. So if you see the values such as that, you need to not give aldosterone antagonists, or you should probably withdraw them. And Cara and I were discussing this. We shouldn't give potassium supplements when people are on aldactone, because it's potential for causing hyperkalemia. Occasionally in hospital practice you have to, because when you're giving intensive diuresis with intravenous furosemide, sometimes do get hypokalemic. And hypokalemia is a danger when you've got severe heart failure. Now, a new drug which is now a class 1 indication for heart failure is the drug valsartan combined with a neprilysin inhibitor, sacubitril. And sacubitril inhibits neprilysin, which actually reduces vasoactive peptides, those are them, and contributes to vasoconstriction, and also interferes with the aldosterone, renin-aldosterone axis, promoting sodium retention and left ventricular remodeling. So those are all adverse effects, and sacubitril tends to reverse those effects. And so this drug, which is called Entresto, I don't think it's available yet, but I'm sure it will be soon, and that will become a class 1 recommendation for heart failure. It was superior to enalapril 10 milligrams twice daily for major cardiovascular events and survival. So that's something which we look forward to using. Ivabradine is something which we have never used, but it has got a class 2A recommendation for patients who are not adequately beta blocked despite optimal doses of beta blockers, and that may be useful to reduce the heart rate further and cause improvement, or would be. Intravenous iron, I think, is a little bit controversial. It's got so far it's got a class 2B recommendation, but I think there are circumstances where it would be advised. Prednisone, we see people in hospital who are given prednisone, moderate dose for lower respiratory tract infections, and they develop heart failure, particularly the elderly, and so that has not been shown to be beneficial unless you've in the absence of bronchial asthma or COPD. I just thought I'd mention that. So the class 1 medications, here they are. These are the 3 beta blockers which have class 1 indications for treatment of heart failure. I don't think there's much to separate them. My preference, we all have our little preferences, I think, about what to use. Mine are carvedilol or metoprolol, but bisoprolol is something I don't haven't had a great deal of experience in using, but can be used.
It's pretty easy to up-titrate the Soprolol, so I use it quite a lot actually.
Do you?
Yeah.
Okay, yeah, okay.
Individual variation, they're all good.
ACE inhibitors, again, the same principle, gradual up-titration, but it's got to be steady and persistent, unless you're really forced backwards. That's a bad sign, by the way. If you're forced to withdraw or cut back on treatment, it usually means you've got a bad situation with a poor prognosis. So it's worthwhile trying to really push ahead with those up-titrations. Same with the others. Loop diuretics need to be given if you've got obvious congestion so that the oral tablets work better. This is just a weight chart of someone's in hospital with advanced congestive heart failure, showing that you have to be in hospital sometimes for 2 to 3 weeks with intravenous furosemide, sometimes dobutamine, lots of potential comorbidities, DVT and renal failure and all sorts of things, PICC line. That's a pretty, and we see that frequently. Our cardiology ward at Auckland is often a third full of patients of that sort. Now, the preserved ejection fraction situation is one which is evolving very rapidly, and I'm not going to try and tell you too much about preserved ejection fraction at this stage because it's very complex. It's not quite the same as reduced ejection fraction, although it does share various characteristics. The main thing here about the preserved ejection fraction, it's almost as common as reduced ejection fraction, mostly affecting the elderly, perhaps, and perhaps women are more likely to be affected as well. The thing about it is that there are 2 trials in 2006 which showed that the survival of preserved ejection fraction and those with reduced ejection fraction was pretty much the same. There wasn't much difference at all. And so that despite having a reasonably normal left ventricular contractility, your outcome can still be very poor. How do we diagnose it? Well, it's not easy. You have to have you normally would look for a BNP, but very occasionally your BNP can be near normal. And you can look at it also with diastolic parameters on Doppler, but again, that may not be very helpful. We have to consider all possible other conditions which may mimic it, such as coronary disease or cardiac amyloid in the elderly, constrictive pericarditis and pulmonary vascular disease, not due to left-sided heart failure. So the diagnosis is largely by exclusion at this stage, but there are more sophisticated tests which one can use if you're in doubt. The treatment, however, of this condition is really fairly. There's not much treatment you can give except to lose weight, treat hypertension, encourage activity, use diuretics, treat depression and things like that. All these trials here of ARBs and sildenafil were negative, but there are ongoing trials, many of them in fact, many ongoing trials now to look at this condition, and hopefully we'll see some effective treatment in the future.
And I guess just to answer the question from before, sometimes you need a lot of diuretic in someone with preserved or reduced ejection fraction, but we see that not uncommonly. I would be very careful to find out about your patient's fluid intake. It would be
1200.
Yeah. Sorry?
1200 ml.
Yeah, so that's a pretty difficult fluid restriction to stick to, but if they are sticking to that, good on them. Salt reduction, and sometimes these people need 250 milligrams twice a day of furosemide, or 500 milligrams orally of furosemide.
Yes. There are 2 new anti-diabetic drugs coming out. Well, I'm going to say coming out in the literature. I think Pharmac haven't even debated them yet, but they could also prove to be very effective, but we don't know yet.
There's a drug called furosemide, Diptol, very commonly used in USA and India, but not available in New Zealand.
So it's a loop diuretic.
Is it any better?
No, I don't think so. Sometimes, and we talked about this before, in some people Buronex seems to be more effective than furosemide in individuals, and I think sometimes it's a little bit better in people with congestion. So that might be something to try if you're really struggling with frusemide.
And in diastolic failure, what is the use of IV furosemide and how often?
So I think it depends on the patient. The other thing I sometimes do is I add in a bit of bendrafluozide with the frusemide, and that seems to be quite effective in some people. Using 2 different diuretics.
Last question. Why don't we have a clinic, like a cardio CHF clinics in our DHBs?
All of the DHBs have big heart failure nurse-led clinics, as far as I'm aware.
I am not aware of one at the Manukau district.
Yes, they do. They definitely have heart failure nurses.
My mother had this problem. She wasn't referred there.
Yeah, so you should. So there definitely are multiple heart failure nurses and a couple of doctors who specialise in heart failure at counties and at Waitemata and at Auckland. So definitely, I think referral to a heart failure clinic is a good thing to do for a complicated patient. The nursing staff provide excellent education as well and can help with drug up titration. So,
Dr. Mayana Lund, she
yes.
takes the one at counties.
Yes, she does.
Been going for years.
Yeah. Yeah. So I'll just discuss, and we've got 2 minutes. So I'll talk fast. So this is just really to illustrate one of my patients who truly does have heart failure with a normal ejection fraction. And I've been looking after him for about 10 years now. He presented to me at the age of 70 with the heart failure syndrome, with breathlessness, orthopnea, nocturnal dyspnea and ankle swelling, and had been started on frusemide and things were a little better. He is a man with multiple cardiovascular risk factors, including hypertension, type 2 diabetes and high cholesterol. And he didn't have angina, but he did get breathless on exertion. He had a physical job and would get breathless with that. When he came to see me, we did some investigations, including an echo. I wanted to look at his renal arteries with his significant history of hypertension, wondering about atherosclerotic renal artery stenosis, and imaging his coronaries. In fact, he had very significant coronary artery disease. We did a CT first and then went on to an invasive coronary angiogram. He has severe 3-vessel disease with severe disease in the LAD, moderate to severe disease in the circumflex and an occluded right coronary artery, prognostic coronary artery disease. His echo showed a normal ejection fraction. He had severe diastolic dysfunction or restrictive filling on his echo. Biatrial dilatation, which is a left atrial dilatation, reflects increased wedge pressure, increased LA pressure, and that causes heart failure, and some valvular regurgitation. He also had pulmonary hypertension, and that's related to his elevated left-sided filling pressure. So this is a very common cause of pulmonary hypertension. And he came forward to CABG. He had persistent heart failure symptoms after his bypass operation and had quite difficult to manage congestion with significant fluid overload, marked ankle edema and breathlessness. But with sort of hard work and optimisation of his congestion, of his high blood pressure, in fact he's on Buronex and other treatment. He's now really asymptomatic. He hasn't had issues with fluid overload for years. He continues to work out at the airport in a physical job, despite his age of 77 or 78 now. And he's had a very good response. He's gone from having severe diastolic dysfunction with treatment of his hypertension and ischemia to now only having moderate diastolic dysfunction. So that's quite nice to see, and is much, much better. I think we're probably due to finish, but are there any questions that people have? We haven't been as interactive as we should have been. Yes?
Is there any role of metolazone in the general practice?
So it can be quite helpful in the setting of significant congestion. I don't use it very much because it's pretty hard on the kidneys, but in someone with intractable heart failure, then it can be quite effective. Arthur, do you?
I use it quite a lot.
Yeah.
You can get a very unexpectedly vigorous diuresis. I'm a bit cautious about using it in practice, I think, unless they have been trialled in patients generally.
Yeah, I tend to use bendrafluozide and furosemide together first, and kind of reserve metolazone for people that are in big trouble at the back there.
How much is this, like safely you can give furosemide in community, orally? They keep increasing the dose and they still need IV flushes from time to time, and then there's discharge back to go back to oral GP to titrate the oral furosemide dose. They are already reaching up to 500 a day.
Yeah, so some people, I mean, it's not very common, but there are definitely people who need a lot of frusemide, and in my experience, it often is the preserved ejection fraction patients. Certainly, we've had people who've come to transplant with hypertrophic cardiomyopathy, for instance, who've been on 500 milligrams BD of frusemide, and that's kept them pretty good. It is very individually variable, and I guess safety depends on how well you monitor them. If they're well and their renal function is okay, then it's probably fine. Do you have other?
No, I mean, frusemide doesn't cause renal disease. It's actually the effect of low blood pressure.
Yes.
And low perfusion.
Yeah. So I think that is a very variable. You know, the renal patients often are on a bucket of frusemide.